Guys, let's start our lectures. It's all about the antimicrobial prophylaxis in surgery. So, antimicrobial prophylaxis in surgery. This one of the important topic to reduce consume of the antimicrobial agents in general, and it's all about the rational use of antimicrobial drugs in health system. So this is one of the examples of the complications after the incisions in surgery. You can see here the redness pus after the antimicrobial after the surgery. So now let's talk about the surgical site infections. Surgical site infections are potential complications associated with any type of procedures and are among the most preventable healthcare associated infection. So a little bit about statistics, guys. So about 80,000 hospitalized patients in Europe have at least one healthcare associated infection on any given day. In Europe, surgical site infections are the second most frequent type of healthcare associated infections. It's about 19.6%. Surgical site infection episode year, we are here. In the United States, the overall surgical site infections rate was 0.9% in 2014. This data taken from the 3,654 hospitals over 2 million over 2.5 million surgical procedures. Surgical site infections are the most frequent type of healthcare associated infections on admission. Surgical sepsis accounts for approximately 30% of all septic patients. Surgical site infections are the most frequent type of healthcare associated infections in low and middle income countries, and rates are significantly higher than in the high income countries. So 11% on average. Definitions of surgical site infection. So, by the definitions of the Center for Disease Control in the United States, they say that it should be half equal or less than 30 days of surgery, or within more than 30 days of surgery, or within a year in the cases of implants, especially orthopedic implants or cardiac implants. So the classifications of the surgical site infections are given above. They can be superficial, deep, and with the involvement of organ and space. So this is very famous pictures taken, given the surgical site infection. Superficial is skin and subcutaneous tissue. Deep soft tissue, it's a deep incisional surgical site infection, and with the involvement of organ and space, surgical site infection, with the involvement of surgical site infection. So what are the risk factors for surgical site infections? This is the surgical factors can be like duration of time, duration of surgical operation, patient-specific factors like, for example, age or comorbidities, local and systemic factors. The factors influencing surgical site infections or patient risk factors, that's local factors like high bacterial load, wound hematoma, necrotic tissue, foreign body, obesity, and systemic. It is advanced stage, shock, diabetes, malnutrition, alcoholism, steroids, chemotherapy, and immune compromised patient, like patient on corticosteroids or cytostatic drugs. Um, this can be HIV patients, something like that. Factors influencing surgical site infections, it is antibiotics. Can be prophylactic or therapy, can be given as a prophylactic or therapeutic. Surgical risk factors. It can be type of procedure, degree of contamination, duration of operation, urgency of operation, skin preparation, operating room environment, and antibiotic prophylaxis. So there is a given classifications of wound. So wound classified as a clean, contaminated, and dirty. So what is the clean wound? Clean wound, it's a non-traumatic elective surgery on GI tract, respiratory tract, genitourinary tract, not entered in that case. So examples given, it's a mastectomy, vascular or hernias. Infection rate approximately 2%. Clean contaminated, it is the respiratory, GI tract, urinary tract entered with minimal contamination. It is the gastrectomy, hysterectomy, for example. And the infection rate equal or less than 10%. Contaminated. Open, fresh traumatic wounds. Uncontrolled spillage. Minor break in sterile technique. This is the ruptures AP, emergent bowel resection, and the infection rate approximately 20%. And dirty wound, it's open, traumatic, dirty wound. Traumatic perforation of hollow viscous frank pus in the field. So it's intestinal fistula resection, for example, and it is the cause infections rate of more than 30 to 70%. So what you have to do, you have to first prepare the skin around the operative site with an appropriate antiseptic agent, including preparation based on alcohol, chlorhexidine, or iodine iodophores. Evidence class 2. Next, you have to administer prophylactic antibiotic for most clean, contaminated, and contaminated procedures. And selected clean procedures use antibiotic appropriate for the potential pathogens. So, as you can see, the evidence strong class 1 data for the administration for prophylactic antibiotic. And it is given for clean, contaminated, and contaminated procedures. Second, administer prophylactic antibiotics within 1 hour before incision. Administer prophylactic antibiotic within 1 hour before incision. And for some antimicrobial agents like vancomycin and fluoroquinolones because of the pharmacokinetic properties of these drugs. You have to administer this antibiotic 2 hours before the incision. So next, guys, you have to use higher dosage of prophylactic antibiotics for morbidly obese patients because of the pharmacokinetic properties. Next, guys, carefully handle tissue, eradicate dead space, and adhere to standard principles of asepsis. Dose prophylactic antibiotics with short half-lives intraoperatively if operation is prolonged. For cefazolin, if operation is more than 3 hours, or if there is extensive blood loss. So, one of the most given for prophylaxis, antibiotic prophylaxis in surgery, this is the cefazolin, because the cefazolin is the drugs which are very effective against the skin infections. And why we give the antimicrobial agent for extensive blood loss? Because the dose of in the plasma, the dose of antibiotic in the plasma significantly reduce if the patient have the extensive blood loss. Discontinue prophylactic antibiotics within 24 hours after the procedures. 48 hours for cardiac surgery and liver transplant procedures. Discontinue prophylactic antibiotics after skin closures. And the meta-analysis, you know that the meta-analysis, the higher evidence class, support only single-dose regimens for prophylaxis. Monitor wound for the development of surgical site infection post-operative days 1 and days 2. Treatment of surgical site infection. Opening the wound. For most patients who have had their wound opened and adequately drained, antibiotic therapy is unnecessary. So guys, open it and adequately drain it. It's a very important things. Treatment of surgical site infection. Use antibiotics only when there are significant systemic signs of infections. For example, temperature higher than 38.5 degrees or heart rate greater than 100 beats per minute. Erythema extends more than 5 centimeters from the incision. And only in that cases, guys, you have to apply antibiotics. Principles of antimicrobial prophylaxis. So the main aim of the principles of antimicrobial prophylaxis is prevent surgical site infections, morbidity and mortality. Optimize the patient's surgical procedures and overall outcomes. Select the ideal agent and use in an appropriate way. If thus work against the pathogens most likely to contaminate site with considerations of their resistance patterns. Shortest effective duration. Correct administration to ensure optimal concentration during the procedure. Minimal adverse effects. Adverse drug reactions from the antibiotic. Reduce that category. Selection pressures for resistant organism. and complications such as Clostridium difficile infections and cannula site infection. Patients with no nasal carriage of Staph aureus should receive perioperative intranasal applications of mupiracin 2% ointment with or without a combinations of chlorhexidine body wash. MBP alone, without the administrations of oral antibiotics, should not be used in adult patients undergoing elective colorectal surgery. In patients undergoing any surgical procedures, hair should either not be removed or, if absolutely necessary, should only be removed with a clipper. Shaving is strongly discouraged at all times, whether preoperatively or in the operating room. Surgical antibiotic prophylaxis should be administered before the surgical incision when indicated. Surgical antimicrobial prophylaxis should be administered within 120 minutes before incision while considering the half-life of antibiotics. Surgical hand preparation should be performed either by scrubbing with suitable antimicrobial soap and water or using a suitable alcohol-based hand rub before donning sterile gloves. Alcohol-based antiseptic solution based on chlorhexidine for surgical site skin preparation should be used in patients undergoing surgical procedures. Intra and postoperative measures. Adult patients undergoing general anesthesia with endotracheal intubation for surgical procedures should receive 80% fraction of inspired oxygen intraoperatively and if feasible in the immediate postoperative period for 2-6 hours. Surgical antibiotic prophylaxis administration should not be prolonged after completion of the operation. So, antimicrobial is parts of the surgical site infection puzzle. Yes. And here given the WHO, the pictures taken from the WHO, guys, you have to look that one. Ensure patients better shower before the operation. Do not shave patient. Only use antibiotics when recommended. Use chlorhexidine alcohol-based antiseptic solutions to prepare skin. Surgical scrub technique, hand wash or alcohol-based hand rub. During surgery, ensure all surgical equipment is sterile and maintain asepsis throughout surgery. Limit the number of people and doors being opened. Do not continue antibiotics to prevent infections. This is unnecessary and contributes to the spread of resistance after surgery. And check wounds for infection and use standard dressing or primary wounds after surgery. Risk of prolonged surgical prophylaxis. So, by the Harvard et al., they compared the effect of short versus prolonged perioperative antibiotic prophylaxis on surgical site infections and acquired and acquired antimicrobial resistance in an observational 4-year cohort study in more than 2,641 patients who underwent coronary artery bypass graft surgery. After adjustment for possible confounding factors, prolonged perioperative antibiotic prophylaxis was not associated with a decreased risk of surgical site infection. It was correlated with an increased risk of isolations of Enterobacteriaceae or Enterococci with acquired resistance to the administered prophylactic agents. Examples: cephalosporin or vancomycin. So, opportunities for surgeons to improve antibiotic stewardship given in the table. Limit perioperative antibiotics. Discontinue use of topical antibiotics. Fixed antibiotic durations after source control. Discontinue antibiotics after appropriate incision and dressing. Limit antibiotics for uncomplicated diverticulitis. Limit treatment of asymptomatic bacteriuria. Limit treatment for asymptomatic Clostridium difficile. So you have to ask before or after the operations some questions, like indications: is it needed at all, and post-operative, is it still needed? Drug considerations, for example, colonizations with methicillin-resistant Staphylococcus aureus, screening, allergies, guidelines, pre-existing infections, recent antibiotic use, prolonged hospitalizations, what is available in the theater, time, administer within 60 minutes, knife to skin, and after post-operatively defined documented duration, route of administrations, support by evidence, not topical administrations, irrigation, pests, cement and washes. Infection control, always dose, blood loss, long procedures. You have to consider repeat dosing, weight, consider larger dose. And post-operatively, patient weight also plays a great role. So the obese surgical patients, now you know that the obesity nowadays, this is one of the big problems which are lead to the non-infectious diseases. Obese patients do not appear to have a higher risk of postoperative complications or mortality than non-obese patients, but the risk of surgical site infection is higher in obese patients and increases as their BMI increase. Obesity per se was identified repeatedly as an independent predictor of surgical site infections in different populations of patients. Obesity is a risk factor for surgical site infections after both elective and urgent procedures. Dosing of antibiotics in obesity. There is a lack of data for most antibiotics regarding dosing in obese and morbidly obese patients. Knowledge of pharmacokinetics and pharmacodynamics will assist with dosing. Only a limited number of studies have been conducted to evaluate obesity-associated physiological changes and their pharmacokinetic ramifications. Some antibiotics may require higher doses at the same frequency, whereas others may require more frequent dosing. Prophylactic antibiotic challenges, significant limitations. Optimal choice of antibiotics had not and still has not been established. Selected antibiotic agents' effectiveness according to the type of surgery remains to be assessed. Variability in antibiotic pharmacokinetics within various types of surgical patients and populations. Distribution of antibiotic concentrations at the site of infection. Antibiotic pharmacokinetic pharmacodynamic characteristics. Optimal pharmacokinetic pharmacodynamic surrogate markers targets within various types of surgical patients, populations, or type of surgery. Appropriate antibiotic dosing and redosing. Patient characteristics such as obesity, sepsis, trauma, changing patterns of antimicrobial resistance may vary by type of surgery, may vary by region and by hospital. Multi-drug resistance pathogens and multi-drug resistance pathogen risk factors. Key pathogen susceptibilities, resistances, prolonged hospitalizations before surgery, exposures to antimicrobial therapy, immune suppression, other relevant risks for opportunistic multi-drug resistant pathogens, and prior colonizations with MDR pathogens. So guys, any questions? Thank you very much for the lectures, to attend the lectures.